lectures so far, but we're going to get more in detail on problems that can arise when the blood pressure is too high and when the blood pressure is too low. And it's a spectrum. So there's some blood pressures we're going to see that are considered elevated, some that we could treat as an outpatient, and then some that are medical emergencies that need more acute treatment. And same with hypotension. It's all on a scale, and we're going to go in depth a little bit further here. Couple of facts about hypertension and its prevalence. Hypertension is the most common reason non-pregnant adults visit the physician's office, and the most common reason for use of prescription drugs. So this is very, very common. About half of adults in America have hypertension, and the prevalence increases with age, right? Because the arteries as we age get a little stiffer, and the chance of having high blood pressure goes up with age, specifically over 60 years old. The highest prevalence is in non-Hispanic African American adults. Only half people with hypertension are controlled. This is why it's called the silent killer, because it usually doesn't cause symptoms until it's very out of control or you've been having high blood pressure over time for a long time. And when we talk about blood pressure, I know you guys know this already, this is just a little refresher. We're talking about the arterial pressure in the systemic circulation. And going way back when to PD lab and like the first lecture we ever had together, systolic blood pressure is the pressure in the heart during contraction, and diastolic blood pressure is the pressure during heart filling. So both of these could be either high or low or within normal parameters. Things that influence blood pressure are cardiac output, right? Our heart rate times our stroke volume. Our actual blood volume, so anemia, hydration, fluid overload is going to affect this number. The total peripheral resistance, so vasoconstriction or hardening of the peripheral arteries is going to affect this, or vasodilation is going to lower this of the peripheral vasculature. And compliance of the vessel wall, how stiff or flexible it is. This chart is super important. This is definitely know it, love it, remember it forever. So normal, they changed these guidelines a little bit in 2003. I say that now because like when I was a student, that was like the recent change in guidelines, but that's like 20 something years ago. So normal blood pressure is going to be considered less than 120, systolic and diastolic number less than 80. Elevated is 120 to 129 systolic and less than 80 diastolic. High blood pressure stage 1 is considered 130 to 139 or 80 to 89 systolic. And stage 2 hypertension is 140 or higher or 90 or higher. Hypertensive crisis is anything over 180 and diastolic over 120. And these are all, we manage all of these differently. How do we manage them? We're going to go back to what normal physiology is. So controlling the blood pressure, we're going to target whatever we think is going on that's causing the hypertension. So cardiac output, so heart rate and stroke volume are going to play a role in how we treat this. Stroke volume has a lot to do with autonomic nervous system, the contractility of the heart, and the venous return. So blood volume and venous tone are going to affect this. Then the TPR, or total peripheral resistance. These are things like vasodilatation and vasoconstriction that are going on physiologically. There's medications that we can use to combat if the blood pressure is too high or too low. Blood volume control, so the RAS system that we've talked about, renin, angiotensin, aldosterone system, primarily hormones from the kidney that affect fluid control and vasoconstriction in the body, natriuretic peptides, and antidiuretic hormones. So medications that combat this would be what? We talked a lot of them are heart failure medicines too that we talked about for blood pressure. ACEs and ARBs, 100%. Diuretics. What about aldosterone, eplerenone, right? That'll affect the system, lower the blood pressure. Any diuretics, so thiazides, loop diuretics, more so for like volume overloaded patients, CHF, are going to help us treat blood pressure from that way. And the neuroendocrine and renal systems are what we're targeting when we're treating high blood pressure or low blood pressure. Taking a blood pressure, this is a refresher too, because I know you guys have learned this already, but it's so important before you go treating any type of blood pressure, you want to make sure you have an accurate, good measurement to go by. So if we're in the outpatient setting, we're going to let a patient, the medical assistant is going to bring the patient in. They're probably going to be nervous. They either had to wait 2 hours, so their blood pressure is going to be high. Maybe they had coffee. Maybe they were smoking that can raise their blood pressure. These are all things you're taking into consideration. And offices sometimes counsel patients, like if their blood pressure is elevated, to not smoke, not have caffeine 30 minutes before the visit, because that could raise it. The patient's going to be seated, not crossing their legs, with 2 flat feet on the floor for 5 minutes to let them get acclimated to the seated position. You're going to remove the clothing from the arm. If you have, like a thick sweater on, you're not going to get an accurate blood pressure. And we're going to make sure our blood pressure machine is properly calibrated. So if your office or the ER or hospital, wherever you are, is using an electronic cuff, you want to make sure that's accurate. Sometimes if you suspect if it's not lining up with what's going on with the patient clinically, maybe you get a manual cuff and take it yourself. You also have to make sure that you get the correct cuff size. This has happened very frequently, where if the medical assistant or nurse comes in and says the blood pressure is high, you want to make sure that they have the right cuff size. Because if it's too tight, it could falsely elevate the blood pressure. If it's too loose, it could make you look like you have a lower blood pressure. So the parameters in centimeters are here. So definitely make sure you have the right cuff size. For the first visit, we're recording the blood pressure in both arms, and we're using the arm with the slightly higher reading. And we're separating repeated measurements by 1 to 2 minutes in between. We're going to use, if it's like the first encounter, we're using the average of the first 2 readings obtained on 2 different occasions to estimate the individual's level of blood pressure. And of course, we're recording the systolic and diastolic blood pressure. And we're talking to the patient, oh, you're a little elevated, you're a little low, doing patient education. So how do we diagnose hypertension? Is it just if someone comes in and they have one single reading and then we're like, okay, let's start meds? No, right? You have to make sure, 1, you do your proper technique in your office visits. 2, you're going to check the blood pressure on 2 separate occasions. So 2 readings on 2 separate occasions, over 130 over 80, make the diagnosis of high blood pressure in a patient, not just a single isolated reading. So if you even want to go a step further and be extremely thorough, technically you're supposed to take the initial blood pressures in both arms and the leg. So why would we check the leg as well? What's that? So ABI index is a different method that you only check blood pressure. That's like a specific test you would do. That would be helpful, but not for like screening just everybody. But you're right in that we would check it if there's a difference. Peripheral arterial disease could cause a much lower reading in the legs. what else are we going to be able to diagnose if there's a difference in blood pressure from the arms to the legs?
The aortic coarctation.
Yeah, coarctation of the aorta, right? If there's that little stenosis in the aorta. Sometimes with subclavian steal syndrome that we talked about last time, that if that's severe enough, it can cause a difference. So that's the purpose of why we would take it in the leg. You guys are probably going to be like, I've been a new patient. No one's ever taken a blood pressure in my leg. So, but for clinicians, for you guys going out into the field, you're going to know that that's why you would take it in the leg if you're suspecting of that. And we're also going to palpate all the pulses and auscultate for bruits, especially in the renal arteries in the abdomen and also in the carotids. So like we said, the office blood pressure measurement over 2 to 3 visits, they have to be spaced out a week apart. And the average blood pressure is over 130 or diastolic over 80 is the diagnosis of hypertension. So what happens if you suspect that the patient is just nervous and every time they come see you, their blood pressure is elevated? White coat syndrome, right? Like it's probably us. You can try one thing. You can try just coming in scrubs only without the white coat, see if that helps. Usually it doesn't. Usually it's just the office that will make them nervous. But how we can diagnose this is home monitoring. So you can do this 2 ways. One is if your office has what we call ambulatory monitoring, where you actually set your patient up with a 24-hour blood pressure cuff, and every hour they wear it, every hour whatever they're doing, they'll check the blood pressure on the patient and it'll inflate and it'll record a reading. And then you get the whole 24-hour summary to see if they truly have high blood pressure when they're not in the office. If you don't have access to that or it's not covered by insurance, a patient can have their own home monitoring, like whatever blood pressure, an Omron from Amazon or CVS or whatever medical supply, and you counsel them on how to take a proper blood pressure, which is seated for 5 minutes, no clothing on the arm, they hit the button. And you're going to find some patients are going to be like, chug 2 cups of coffee, go run an errand, then check it. And those are things you're going to ask them and confirm that they're checking it the proper way. But they're going to do that for a week, twice a day, once in the morning, once at night. And then you'll look at those recordings. And if they have hypertension at home as well, it's not white coat hypertension. If they are totally normal at home, you don't need to worry about the blood pressure in the office that's spiking because it's the medical field that's making them nervous. So that's white coat hypertension and how we can diagnose that. So if the initial visit, the blood pressure is 160 systolic or over 100 diastolic with end organ damage, you can make the diagnosis of hypertension on that visit alone. Or if it's 180 over 110 with no evidence of end organ damage, you can say they have high blood pressure. So what are some ways we could see end organ damage in the office or in the hospital for these patients? If someone has the blood pressure of 160 over 100, what are we? Altered mental status? Yes, that would be more concerning of like a hypertensive urgency. I'm talking just like we diagnose high blood pressure. What's that?
You mean like in general?
Yeah.
Like what can you see in somebody in general if you think they have that?
Yeah.
Maybe they have a fistula. Maybe they have
like a bruit somewhere.
Yeah, or maybe like they have like CKD.
Exactly. Is that what you're gonna say? Okay, you guys are aligned. CKD, like say they come to you with blood work from their primary, and they have an elevated creatinine. You could assume that's end organ damage. What if we get an EKG and they have LVH? That's sign of end organ damage, right? There's remodeling of the heart. You can assume that from the EKG. So they probably had this for a long time. And other blood work, what if they come in with a slightly elevated troponin, like a type 2 demand type of thing? You're seeing them in the ER and their pressure is 160 over 100. That's end organ damage, right? If there's some strain on the heart from the high blood pressure, we can count that.
What about ocular deficits?
100%. If they say they're seeing the eye doctor and there's papilledema or cotton wool spots, things that show they've had high blood pressure over time, that counts as well. So those are the things that you're looking for and asking in an office visit. Consequences of hypertension, we talked about this like a million times in our other courses, but just a reminder, so it can weaken the vasculature, right? We saw that in dissections and aneurysms, hypertension as a cause for that. So it can weaken the vasculature. It can cause scarring and stiffening with that high pressure over time, increases the risk of blood clots and plaque buildup. Remember our endothelial cells in the lining of the vessels that can deteriorate and plaque buildup can get in there. Tissue and organ damage from blocked or narrowed arteries. So if you have high blood pressure because there's plaque buildup or the vessels aren't as compliant enough, that can affect blood flow to arteries, right? Like CKD, the coronary arteries. So we may start to see that over time. And the heart may have to work harder. If there's more increase in afterload, the contraction of the heart needs to be stronger to push past that afterload. And like we saw in heart failure, the heart can compensate to a certain point until it can't. And then maybe they develop heart failure or remodeling of the tissue. Some signs and symptoms. It can be silent, the silent killer like we talked about, or they may have headaches when their blood pressure is too high, nosebleeds from the little capillaries having that higher pressure and bleeding. They may feel a little bit dizzy. They may feel flushed or look flushed, like have a kind of like a reddish face, sweating, blurry vision if there's ocular damage going on. Sometimes people just, their only complaint may be, I hear my heartbeat in my ear. Like, you know, when you're working out and you go for a really long run and you stop and you can like hear your heartbeat, someone with hypertension may have that same experience, but just at rest normally. And impotence. This could be also the only complaint that people may come in with. Major consequences of having arterial hypertension for too long are in this beautiful little algorithm. So if you diagnose hypertension, like we talked about, we're gonna ask ourselves, is there increased afterload? If there is, it can cause systolic dysfunction, LVH, and increased myocardial oxygen demand. If there's increased systolic dysfunction, that could lead to heart failure. If there's LVH, that could lead to diastolic dysfunction, also lead to heart failure. If there's increased myocardial oxygen demand, that could lead to an MI or chronic ischemia in the heart over time. If hypertension starts leading to damage to the arteries, it accelerates plaque buildup. So as we know, plaque doesn't discriminate. So we can have problems with the coronary vessels, plaque buildup in the cerebral vessels, which can cause an ischemic stroke, plaque buildup in the aorta, which can lead to aneurysms and dissections that we talked about last class. And then if we go down this channel of we're weakening the vessels of the walls, that could happen anywhere too, right? There's 60,000, was it miles? Yeah, 60,000 miles of vessels in our bodies. So it could weaken anywhere. In the cerebral vessel, that could lead to a hemorrhagic stroke over time. If it weakens the renal vessel, it can lead to problems with the kidneys and ultimately renal failure. And then, as you said, Anne, with the ophthalmic vessels, you could have retinopathy as consequences of this. So this is why it's so important in office visits to make sure we get an accurate reading and diagnose hypertension early and aggressively to avoid these more serious complications of having hypertension over time. And then there's a couple classes of classifications of hypertension. There's primary and secondary causes. Primary or essential hypertension is most of the cases, like 90 to 95% of high blood pressure cases. No identifiable cause. It's too early for me to be losing my English. Usually this is around like 1 or 2 o'clock. This is usually genetic. Primary hypertension, think genetic component. Secondary hypertension is more rare, 5 to 10% of hypertension cases. But it's really important that you recognize these red flags because just treating the number alone will not improve the patient's high blood pressure. And also your boards love secondary causes of hypertension, like really loves to crack down on those. So the most common cause of secondary hypertension is chronic kidney disease. So a UTI that goes too far can cause this, polycystic kidney disease, or CKD from another type of comorbidity. Endocrine disorders, so hyperaldosteronism. Did you guys have endocrine yet?
Mhm.
Okay. So hyperaldosteronism is when, the RAS system that we talked about is when the aldosterone levels are too high, causing high blood pressure. How would we see this in the lab work? So one, they would have high blood pressure. What's that? So actually hypokalemia, yes. So the potassium will be low and like they won't really be on a diuretic and they'll say like they don't have diarrhea, they don't have anything else that can cause that. And secondary causes of hypertension, usually you will treat them as primary. So we'll go over how the initial management of primary hypertension, but they'll be on like 3 or more agents and nothing's touching their blood pressure. And that's because there's a secondary cause that we need to treat. Also, these patients generally present at a younger age. So if someone presents with high blood pressure, like in their 20s to like 40s or 50s with no other comorbidities, we suspect either there's a real genetic cause or it's secondary cause of hypertension we look for. Other things that can cause secondary, what's that? Secondary, yeah. Sleep apnea, pregnancy, or renal artery stenosis. So for sleep apnea, this I feel like really blew up in the last 10 years since I've been practicing as like a real target for treatment. Untreated sleep apnea can lead to a lot of things, and one of them is high blood pressure. So sometimes we would diagnose this in patients if we put a 24-hour blood pressure monitor on them, and it also inflates and deflates during sleep. It kind of stinks because like you're probably like woken up by your blood pressure cuff like every hour, but they'll have higher blood pressure readings at night. So at night, your body should be in the parasympathetic state, lower heart rate, lower blood pressure, and you'll see spikes in their blood pressure at night. And that may make you suspect sleep apnea. And if you treat that, their blood pressure might get better. Pregnancy, because of the extra volume, your blood volume double, your hormones are crazy, so that could be a secondary cause, and renal artery stenosis. So this could be congenital renal artery stenosis, where you just have the narrowing of the arteries genetically, or it could be from PAD in that specific area of the kidneys. You could have unilateral renal artery stenosis or bilateral renal artery stenosis, and they're treated a little bit different, and we'll talk about that. So that was a lot of information. We're going to summarize that in a lovely acronym of A, B, C, D, E of secondary causes. So A is apnea, aldosteronism. B, we think of bruits and bad kidneys. So if someone has renal artery stenosis, you're going to hear bruits, turbulent blood flow in the renal arteries, and bad kidneys if they have kidney disease. Cushing's and catecholamines like pheochromocytoma, also secondary causes, and coarctation, that's also C. Drugs and diet can also be a secondary cause of high blood pressure that we want to target. Excess excess EPO. Hang on one second. I think so. Yes, so erythropoietin that stimulates bone marrow to produce too many red blood cells, leading to thicker blood. So they could have increased blood volume from too much erythropoietin, and that can cause high blood pressure. And that's a totally different treatment, right, than just hypertension alone. All right, so back to primary hypertension. We think genetics. First degree relatives. When you're taking a history, they may say, oh yeah, my dad has always had high blood pressure, even when he was in his 30s. That's the type of history you might get. Or someone died of an early MI or an aortic dissection at a young age. Effects this has on the heart, it increases cardiac output to be able to push against the increased afterload. The blood vessels develop an abnormal endothelial response, which is a big problem. That's our first line of defense for the arteries against plaque buildup, inflammation, dissection, and changes. So we don't want high blood pressure for too long. The kidneys can be affected from the blood flow regulation. There's inappropriate hormonal regulation, like elevated renin levels. And obesity and diabetes can also be a sequelae that you see with high blood pressure. Clues to secondary hypertension. Like we said already, age is going to present younger, 20 or after, before 20 or after 50. Severity, the blood pressure is going to rise dramatically and more suddenly. The onset may present more abruptly in previously normotensive patients, right? So if you have like an 18-year-old who is otherwise healthy with no medical problems and suddenly they come to your office with high blood pressure, you're going to look for the secondary causes. Same after 50 years old. You're looking for bruits. We're looking for UTIs, causes that could raise their blood pressure. And we're taking a thorough family history. We're also not on here, but we're gonna do an in-depth questioning on their diet. How many cups of coffee are you drinking? How much caffeine do you have in one day? What's your diet like? If they're eating fast food every day, if they're going to the deli every day, these are really high sodium foods, or if they're having like frozen, pre-prepared foods, canned foods that have a lot of sodium in them, or anything pickled, anything delicious. You're gonna take those very seriously and go more in depth than how's your diet? Good. You're gonna really want to ask the questions with these patients. Common initial tests, a UA and a serum creatinine and BUN. That's going to tell us kidney damage, dehydration level, and urine analysis can tell us if they have a UTI or if they're spilling protein into the urine too, which could be a sign of CKD. We're checking potassium levels. Are they too high, too low? Serum glucose levels, microalbuminuria in the urine. We are checking cholesterol levels, and we're doing an EKG that may show signs of long-term remodeling of the heart. So we touched upon causes, but again, we're asking them if they smoke. Smoking cessation can significantly lower your blood pressure. Oral contraceptives, the extra hormones can have a role in raising your blood pressure. So we're going to ask that in the medical history. Alcohol can raise your blood pressure. And then renal causes. So parenchymal disease, like any disease process that has an effect on the kidney tissue. Renal artery stenosis, we talked about coarctation of the aorta. You guys tell me, what do we see in this here. What are these little arrows pointing to? What's that?
The red ones, are they pointing to fairly good?
They are, I see what you mean here, this vasculature, but they're not pointing to that. They're pointing to like the rib. A little bit bumpy? Yes. What does that mean? We did. It's in there somewhere. Get out of the lung, get back into the vessel. So remember, does this look like a 3? It looks like this is what we would call a 3 sign. So if the aorta is like kinked in and there's rib notching from collateral blood flow, it was in the congenital lecture. It's also on the slide. Coarctation. Yes.
Right there.
Yeah, exactly. So coarctation of the aorta, this is how it's going to present on an EKG. It's that 3 sign where these arrows here, it kind of makes an indentation. They call it a 3 sign, and that's the kinking of the aorta. And then the vessels over time will realize they have diminished blood flow to the collateral of to the ribs. Oh my God, why am I blanking on? In between the ribs. Intercostal, thank you, Anne. The intercostal, it supplies the intercostal vessels. So those vessels will compensate by getting larger and more prolific in that area, and that will cause breakdown of the ribs and notch over time. Thank you for your support, Anne. Then endocrine-wise for secondary hypertension, pheochromocytoma, adrenocortical hormonal excess, and thyroid hormone. So hyperthyroidism would be a secondary cause of that. So for a pheochromocytoma and adrenal cortical hormone excess, what would we see? Sometimes this is found incidentally. Did you guys, oh, you didn't have endocrine yet.
Or what the
Theo-
Dr. Bank told us.
Oh,
about.
Okay.
Oh.
For Pheo?
Yeah, she
Okay.
said like you could give them a bunch of meds for it and it's not touching them. There's something you could think about.
Yeah, exactly. As a secondary cause of hypertension. It's a rare non-cancerous tumor that grows on the adrenal glands. So sometimes, so you'd have to get a CT scan of the abdomen to look at the adrenal glands for this. They're also going to present with headaches, excessive sweating, and heart palpitations or a rapid heartbeat, and they're going to have high blood pressure that's very difficult to treat. You're throwing meds at them, it's not touching their blood pressure, you're not seeing it go down at all. Bless you. Okay, so the foundation of treatment for hypertension is always lifestyle modification first and adjuvant medications when they meet the criteria. So weight loss, exercise, diet, salt restriction. Usually you want the patient to stay under 2,500 milligrams of sodium per day. In heart failure patients, we're more aggressive. It's usually like less than 15 milligrams of sodium a day. And to put that into perspective, especially if you go into heart failure, you're going to start like reading labels on everything to counsel your patients on like what is good for them, what isn't. But to put into perspective, one pickle spear has 800 milligrams of sodium in it. So that's like, if you don't have high blood pressure or heart failure, those are things your body can handle. You can handle more than 2,500 milligrams of sodium. But if you have problems with high blood pressure or heart failure, you're much more sensitive to fluid shifts. So 1,500 for heart failure patients. So sometimes like if we had a patient and they had a Costco hot dog, that could be, their legs are like, they gained like 7 pounds in like a couple of days. So they're very sensitive to it. The average person, like with no high blood pressure, no CHF, can handle more sodium than that. Yep. So for hypertension, less than 2,500 milligrams a day. For heart failure, less than 1,500 milligrams a day.
So that's what.
Yeah.
And like, to me, like, something, um, results are,
That was just an analogy that I would use to, you know, encourage patients to like read labels on foods. But usually your office or the hospital will have a printout for them too. And I always love giving patients a printout because you guys know when you go to any office visit, there's so much information thrown at you at once that you don't always remember everything. So that's when giving a printout of like foods that are higher in sodium and foods that are less high in sodium and healthier, you want to give a patient that for patient education. Because also I've had patients swing the other way where I'm like, all right, you need some sodium. You can't just eat low sodium bread forever. So also increasing your potassium intake, like potassium supplementation in the right patient can mildly lower your blood pressure. And the reason for that is sodium and potassium follow each other. So if there's too much potassium in the blood, the kidneys will use sodium to transport it out. So if you have more potassium in your bloodstream, you're going to pee a little bit more. It's kind of like a very, very mild diuretic effect to lower the volume of blood and help the blood pressure a couple of millimeters of mercury. Decreasing alcohol content, decreasing caffeine intake, smoking cessation, and also relaxation therapy. So mindfulness practices, meditation, work schedules, things that are causing stressors in your life. That's the hardest one, I think, to tackle. Let's see. I think I just want to see. I don't think I have I meant to put a chart in on this, guys, but there is like you can counsel patients on numbers for this. So people studied weight loss, and for every 1 kilogram of weight you lose, your systolic blood pressure will drop 1 millimeter of mercury. So if you lose 20 kilograms of weight, you're lowering their systolic blood pressure 20 millimeters of mercury. So that's huge. And it's important to counsel patients on that direct effect. Same with exercise. It's usually like, I think 4 millimeters of mercury if you exercise 90 to 120 minutes per week. So a lot of it could be autonomy with the patient and on their end, lowering the blood pressure. Hopefully you don't need to add medications. And a lot of people are motivated if they don't want to be on medicine right away, or if they don't need to be, you can try aggressive lifestyle modifications first. And also sodium restriction. If they're going fast food every day, if they're having like a can of soup every day, you talk to them about options within their means and lifestyle that they can kind of adjust that to also lower the blood pressure with sodium restriction.
So 1 kg drops about 1 systolic, right?
Yeah, 1 millimeter of mercury, exactly. So that's our foundation that we're counseling patients on. You don't want to skip that because a lot of this stuff won't work as well if a patient is going to the deli 3 times a day, eating a jar of pickles, type of thing. Things that we like to use, diuretics, sympatholytics, vasodilators, and renin, aldosterone, and ACE inhibitors. So first line therapy for essential hypertension are diuretics. Usually it's a thiazide diuretic to decrease the volume of blood. The next line is ACEs or ARBs, so the prils and the sartan. This decreases vascular resistance and volume. Next is calcium channel blockers. All the epenes, so verapamil and diltiazem. These decrease vascular resistance, heart rate, and contractility. Second line are beta blockers, alpha-1 antagonists, all the zosins like alpha-zosin, things like that. Alpha-2 antagonists, clonidine. Usually clonidine's added, you have to take it like a zillion times a day or it's a patch. This is usually reserved for extremely refractory high blood pressure. Direct renin inhibitors, same thing. I have personally never used this. If someone has real refractory high blood pressure and this is your last ditch effort, you could use this to decrease retention, salt retention, and vascular resistance. Now, on your boards, when they ask first line therapy for essential hypertension, you're going to say diuretics. In clinical practice, if someone has a comorbidity where another agent will help, it'll help that comorbidity and treat the blood pressure, you're going to reach for that. And some examples are that, like if somebody comes in and they have new essential hypertension and diabetes, you're probably going to start with 2 agents or a combination pill with an ACE inhibitor, right? Because that's renal protective for diabetics. And you're going to give them a little bit of a diuretic. Same thing with if someone has coronary artery disease and high blood pressure. You may reach for a beta blocker first because that improves their mortality rate by decreasing contractility of the heart. So it varies. This isn't like an exact science. You guys are going to get out into the world and be like, why aren't we using thiazides on everybody? Like, that's what it says. Yep. For the exam, we start with thiazide diuretic always. If they have another comorbidity, you're going to consider a combination pill with an ACE depending on what comorbidity they have. Or say they have a little bit of diastolic heart failure and you need to add another agent. Maybe you add like a eplerenone, right? Which is a potassium sparing diuretic. So it has a little bit of diuretic effect, but also diastolic heart failure will benefit from an MRA. So that's how you're kind of going to think of what you're going to choose first. On your boards, first line, we try a thiazide diuretic if they have no other comorbidities. Also things to caution in the second line of agents. So beta blockers, when do we not want to use those? What if yes. So if their heart rate's too low, what if they have a severe COPD? Are we going to use a beta blocker as a second line agent? No, right? Because it can cause bronchospasm if it's not beta-1 selective. Alpha-1 antagonists, when are we going to really use caution with these? So these are a peripheral vasodilator. So it decreases sympathetic tone. So it vasodilates everything in the periphery. So what patients would we worry about?
Nitrates.
What's that?
They're on the medication that already vasodilates.
Yeah, if you're, yeah. Low, if they have low blood pressure already, 100%. Specifically in the elderly or patients who have frequent falls, because this can cause orthostatic hypertension. So when they stand up, everything, your peripheral vasculature is supposed to vasoconstrict. This is blocking that. So when the patient stands up, they may go down. So that's orthostatic hypotension is a big one with the alpha-1 antagonist. And you may see this in elderly patients. Sometimes they're put on a Zosyn for BPH, right? That's common in elderly males that they need to be on it because their prostate's getting enlarged and then they may have some orthostatic hypotension from this. This is a lovely algorithm that's going to guide how we treat each stage of blood pressure. So normal blood pressure, we are happy. And it's going to be a very quick visit. We ask how their weekend was and everything's great. Slightly elevated BP, we're going to do aggressive lifestyle modifications. We're going to counsel the patient. We're going to do non-pharmacotherapy and reassess in 3 to 6 months. So we're going to ask about their diet. We're going to ask about their caffeine and alcohol intake. We're going to tell them to exercise, lose weight if that's the case, and then we're going to see them in 3 to 6 months for a follow-up. For our stage 1 hypertension, this is when our 10-year cardiovascular risk assessment is going to come in handy. So remember, we use this for patients with elevated LDL and how aggressive we're going to be. We're using the same calculator to assess their 10-year cardiovascular risk to see whether or not we're starting meds from the jump or we're giving them a shot at lifestyle modifications. If they have documented plaques, we are more aggressive with starting them on a blood pressure lowering medication from that point on, because it's more of a risk to them to let them go untreated if they have documented plaque. So we don't want to let them go too high for too long. So say they have no plaque, they have stage 1 hypertension, and their estimated 10-year cardiovascular risk is less than 10%. We're going to do lifestyle modifications, just like we did for elevated blood pressure, reassess in 3 to 6 months. If they are high risk of having plaque or cardiovascular disease in 10 years, or they have documented plaque, we are going to do the lifestyle modifications, start them on a blood pressure lowering medication, and then reassess in 1 month. If the blood pressure goal is met, that's great. We have them follow up in 3 to 6 months. If not, we ask if they're taking the medication. That happens a lot where you start someone on something, they come in, you're like, oh, their blood pressure didn't budge. And you're like, maybe there's something else going on. And then you go and you say, oh, how have you been doing on the medication? And they're like, we didn't start it. And you're like, okay. So then you start back from where you were on counseling them, seeing why they didn't want to take it, if you should try something else that they're more comfortable with. If they were taking it, you can consider adding something or intensifying the therapy, going up on that blood pressure pill. If someone has stage 2 hypertension, you're giving them medication and lifestyle modifications from the start. And then we follow the same algorithm as stage 1 with plaque or at risk for cardiovascular disease. Any questions on that? That's a lot. You just got to spend a little time with it, commit it to memory. Okay. We have a case question. So we have a 63-year-old male presents for a routine physical exam and was found to have a large increase in blood pressure since the last visit when you saw him 6 months ago. Blood pressure was classified as just elevated at that time. So say he was like 129/80. He has a history of high cholesterol. He has no complaints at this time. He's asymptomatic. On exam, his blood pressure is 163/85, and we took it the correct way. It was a good blood pressure reading, the cuff fit, everything was good. He, on exam, has bilateral abdominal bruits, and his labs are pending. Which of the following is most likely true regarding this patient? A, serum potassium will be elevated. B, he has essential hypertension. C, aldosterone levels will be elevated. D, he has hypertensive crisis. E, his blood pressure should be aggressively treated with IV blood pressure medicine. Which one? You said D? B. Okay, he has essential hypertension. All right, we're going to put a pin in that. What else? C, aldosterone levels will be elevated. Put a pin in that one. Anybody else? Also, to take the pressure off, this is a teaching point. I didn't really say the criteria of how to treat everything yet. Okay, so let's go through the answers, why they're right, why they're wrong. So the correct answer is aldosterone levels will be elevated. And this is because it's describing bilateral renal artery stenosis. So in that case, you will have hyperaldosteronism, which will actually show lower levels of potassium in the blood. It's not essential hypertension because we've identified a secondary cause, right? So why do you think I suspect that? So when you hear a bruit, what does that usually mean? Could be found in any vessel. So a bruit is turbulent blood flow. And what can cause turbulent blood flow? Buildup of something, so stenosis of a vessel. So what arteries are in the abdomen? The renal arteries, exactly. So bilateral abdominal bruit makes you suspect renal artery stenosis because any type of stenosis can create a bruit, which is just you're hearing turbulent blood flow through a vessel. If there were no abdominal bruits, this would be essential hypertension. But what tips you off is he's over 50. He had normal blood pressure the last visit, and this kind of spiked. So that's secondary hypertension, right? An abrupt change in blood pressure. And the bilateral abdominal bruit. So hyperaldosteronism, low potassium raises blood pressure. Hypertensive crisis, we didn't define yet, but this usually has to be 180 over 120. And his blood pressure should be treated aggressively with IV blood pressure medication. The next couple of slides are going to go into this, but if somebody has asymptomatic hypertension, you don't use IV medications unless it's a hypertensive emergency. So unless there's evidence of end organ damage, that's when you use IV medication. Excellent. So getting into hypertensive crisis. Urgencies and emergencies. So when we talk about urgency, this is severe asymptomatic hypertension, so systolic over 180 and or diastolic over 120 without signs of end organ damage. So these are the patients that come in to your office. They have this isolating reading. There's no evidence of end organ damage. That could be troponin, renal failure, ischemia on the EKG, ocular findings. So this urgency, you can actually treat with oral medications. You have time to let the blood pressure come down. So you can treat them with like an oral labetalol or an oral medication, keep them in the ER, watch them in the office for like an hour or two if you have the staff to do that, and recheck their blood pressure and see if it comes down. For an emergency, this is symptomatic, shows signs of end organ damage. So kidney injury, hypertensive encephalopathy, papilledema, cardiac ischemia. These are the patients you're going to treat with IV medication and sending them to the ER if they're in the office. When we evaluate hypertensive emergency, we are going to look for a bunch of things. Any head injury. So we're going to get a CT scan, right? Any hemorrhagic stroke, any ischemic stroke from this. Focal or general neurological problems, same thing. If they have neurological hypoperfusion, we're looking at their neuro exam to see if there's any deficits. We're looking in their retina, see if they're having any effects on that. They may have nausea, vomiting if their pressure goes too high. They may have chest pain. They may have shortness of breath. For pregnancy, did you guys have OB yet? That's next semester. Okay, so you're gonna dive into that even more, but preeclampsia is defined as a blood pressure 140 over 80 after 20 weeks gestation. And eclampsia is a severe form of hypertension in pregnancy where you may have a coma, seizures. You have to deliver the baby and treat the mom acutely. So that you will be tested more on in OB. Certain drugs, like you're asking if they consumed alcohol, if they have any problems with erythropoietin, or they're on that to stimulate more. They're on erythropoietin injections for anemia. You need to know that in the history. If they're taking their blood pressure medications, honestly, that's probably going to be one of the most common things you're going to see if you work in the ER. Someone either ran out of their medications, they weren't covered, or they stopped taking them because of a side effect, and then had rebound hypertension and it became a hypertension emergency. Because usually you don't want to abruptly stop multiple high blood pressure medications because of the rebound side effects. You want to taper somebody slowly off of them if you need to lower them. How are we going to test to identify target organ damage? We're going to see ischemic changes on EKG. So we're definitely getting EKG. We are doing a chest x-ray. You may see maybe some heart failure, curly V lines, pleural effusions, peripheral vascular congestion. We're getting a CT of the head. We're getting an MRI of the brain if necessary. A urine analysis, see if protein's spilling into the urine, if there's any UTI. We're checking electrolytes with a CMP and also magnesium. Cardiac biomarkers, we need to know if there's troponin elevation, right? Type 2 demand ischemia, or if it's a real MI, we need to know that. And we're doing an eye exam. So approach to therapy for a hypertensive emergency, we don't want to lower them too fast. And the reason for that is if you abruptly withdraw perfusion, if someone's either been living at 180 for a long time and walking around with it, and then you drop them within the hour to 130, you can cause cerebral perfusion, hypoperfusion, which could lead to brain damage. So generally, we say in most scenarios, it's unwise to lower the blood pressure too quickly as it can cause ischemia. The goal is to lower 10 to 25% of the mean arterial pressure in the first 1 to 2 hours. And then we're going to lower another 5 to 15 over the next 23 hours. If it's really severe encephalopathy and the diastolic is over 130, we're going to use IV nitroprusside, nitroglycerin, labetalol, or nicardipine. For urgency, we have a little bit more time to lower the blood pressure because there's no end organ damage. So we can lower it within 24 hours with oral therapy alone. We don't have to use IV for hypertensive urgency. That's the general rule. There are some exceptions, right? There's some pathologies that we talked about. We need to aggressively lower the blood pressure despite the risk of cerebral hyperperfusion in the following cases. If someone's having an acute ischemic stroke and like an active ischemic stroke, we lower it as quickly as possible. If someone has an acute aortic dissection, right? We talked about this last class. The number one goal is aggressive blood pressure management to prevent the dissection from getting worse. So for an acute aortic dissection, we lower it as fast as we can. Intracerebral hemorrhage, same thing, the brain is bleeding. So cerebral hyperperfusion is kind of on the back burner. The brain is bleeding. You do not want the pressure to be that high. We need to lower it aggressively and quickly. So those three things are the exceptions. And another beautiful algorithm. So if the blood pressure is 180 systolic and or 120 systolic or above, and there's evidence of end organ damage, new, progressive, or worsening, we need to decide if this is a hypertensive emergency. Then we are going to admit to ICU class 1. That's a class 1 indication. We are going to identify if they have any conditions that are going to determine how fast we're going to lower their blood pressure. If they have aortic dissection, severe preeclampsia or eclampsia, pheochromocytoma. If yes, we are going to reduce to less than 140 millimeters of mercury, regardless of how high they are in the first hour, and then under 120, specifically in aortic dissection. The one I really want you guys to know for this is the aortic dissection indication. If they don't have any of these, then we're going to go to the criteria we just talked about, which is reducing the max BP to 25% over the first hour. And then the next 2 to 6 hours to 160 over 100, and then normal over the 24 to 48 hours. So we're going to go slower if there are not those exceptions that we talked about. The exceptions here, and then also the ones on the previous slide, which were ischemic stroke or intracerebral hemorrhage. So if the pressure is 180 over 120 and there's no end organ damage or symptoms, we are just going to reinstitute if they stop taking their meds or intensify their oral antihypertensive therapy and arrange a follow-up. So really important when the blood pressure is this high to determine if it's an emergency or an urgency, because that's the difference between IV and oral therapy. Any questions on that? Awesome. Okay, now we're going to talk about going too low. So hypotension is usually defined as an absolute number of less than 90 millimeters of mercury or relative. So if people live higher at a higher blood pressure than they're used to, and then they drop over 40 millimeters of mercury, that could be hypotension for them. And they may get symptoms of dizziness from that. So that could be relative hypotension for that patient. And that's important to note as well. Orthostatic hypotension is usually going to give you a presentation or a story that it's positional. So when the patient stands up or sits up in bed, their blood pressure is not able to rise appropriately to meet cerebral perfusion. And they may have symptoms of passing out, dizziness, feeling like they're going to pass out, things like that. And this is defined as a drop in systolic over 20 millimeters of mercury, or it doesn't have to be both, a diastolic drop of 10 millimeters of mercury with standing. And this is when you're going to check your orthostatics. Things that can cause this are if you just ate and you stand up too quickly, right? All of the blood after you eat something shunts to your stomach to be able to digest that. So you have less peripheral circulation to go to the brain. Postural, like we talked about. This is more common in the elderly because their baroreceptors and their carotids are not as sensitive as when they were younger. So they detect less quickly when the body goes positionally from sitting to standing. Carotid stenosis can delay this response too. Having narrowed arteries delays the blood from getting to the brain. Certain medications, like we talked about, right? Like the Zosins, the peripheral vasodilators can cause orthostatic hypotension. So reviewing their med list is huge. And also not on here, but I want you guys to jot this down. Things that can lead to impaired autonomic dysfunction are dementia. So you see this a lot in Alzheimer's dementia. They lose autonomic dysfunction. So they get a little unsteady, their blood pressure drops. That is probably the most difficult orthostatic hypotension patient to treat is a dementia patient with BPH because they need to be on those medicines. Some of the medications that treat dementia can also worsen orthostatic hypotension, and dementia patients usually don't remember to stand up slowly and they don't remember to eat or drink enough. So that's really difficult to treat. Another disease process that can affect autonomic reflexes are certain autoimmune diseases. So if somebody comes in and they have severe lupus or rheumatoid arthritis, those can also cause a delayed autonomic reflex effect, and they may have orthostatic hypotension when they stand up. And then one other bullet point before shock that I wanted to talk to you guys about that I didn't have time to update it is vasovagal hypotension. You guys have heard of this before, right? What I want you to remember about vasovagal hypotension is it's when the vagus nerve is stimulated and causes heart rate to lower and blood pressure to lower severely, which can cause symptoms like dizziness, pallor, nausea, feeling like they're going to pass out or passing out. It's the most common cause of syncope. Like when you get a syncope consult, ask the story, there will always be a prodrome for about like 20 to 30 minutes. And the triggering factors can be what? What can cause a vasovagal reaction? What's that?
Like go to the bathroom.
Going to the bathroom? Absolutely. The story might be, oh, I was straining to have a bowel movement and then I passed out. Or I was on the toilet, I had diarrhea and then I passed out. And I felt sweaty and my spouse said I looked pale. And I felt like I was going to pass out. And that's what happened. Definitely bowel movement. What else?
Anxiety.
Emotional stressors, 100%. So severe emotional stress in patients that have more, everyone's vagus nerve is a little more or less sensitive. If you have a more sensitive vagal tone in emotional situations, you could be more likely to have this reaction. What other thing can cause this? There's one other big one. And I'll give you a hint. You guys have procedures.
Needles.
Needles or pain. Seeing blood, exactly. So seeing blood or if a patient has pain. So if somebody has, we see this a lot, we get called for syncope in-house. And if someone's admitted for something like a big tumor or a bowel obstruction or cancer and they pass out, in our cardiology consults, you have to ask the patient, did you have pain right before you passed out? And if the answer is yes, and they give a prodrome of, I was so sweaty, my vision started to go, my pain was so bad, and then they passed out, it's most likely vasovagal. There's good and bad news about vasovagal reactions. It's most common and it's benign, but you have to treat the underlying stressor. So if it's emotional stress, you just have to tell the patient, okay, when you get stressed, make sure you're seated, you grab a glass of water, you try to distract yourself when it's coming on, you make sure you're like lower to the ground. Same thing if it's triggered by pain, you want to control their pain. If it happens on the toilet, make sure that they go to the bathroom with someone next time. And if they feel it coming on, there's rails, they lower themselves, they stay hydrated, things like that. So vasovagal is not up here, but make sure you jot all that down. That's a huge one. You guys are going to see that. And it's definitely a very common cause of hypotension. If you check their vital signs right afterwards, they are going to have sometimes a very scary pulse, like in the 30s, 40s, 30s, 20s, sometimes pauses. And their blood pressure can be like 80 over 60, but it'll come back up and the patient will feel pretty tired afterwards. If you want to like remember vasovagal, think about like playing possum. Like, you know, when you see, well, I don't know if like you commonly see opossums around, but you know, like when they play dead, right? Like, and they're on the side of the road and they play dead because they're like, okay, something happened, I'm freaking out, let me go down. That's kind of a similar pathway to vasovagal. Like everything drops to a point where you're concerned about the pulse and the blood pressure, but it will come back up. You elevate their legs. You maybe give them atropine to raise their heart rate if it's severe, and you can give them fluids, but they'll be okay. Any questions on that? So we're also going to talk about shock. Did you guys have shock yet with Dr. Bang? I think that's next.
You're something leaving.
Oh, you had shock with Halimi? Okay. Sometimes it's different for two cohorts, so I'm not sure who teaches what.
Yeah.
You had it with Halimi? Okay, perfect. So this is just like a refresher. So hypotension, this is when hypotension is causing end organ damage or hypoperfusion, and this is a medical emergency. Sometimes the hypotension or the shock has like a prodrome in itself. There may be a couple of signs before someone goes into fulminant shock. Their heart rate may go up. They may have tachycardia as the first sign because the body's trying to compensate. There's decreased urine output. So if someone says they're not peeing as much or they're admitted to the ICU and you see their Foley bag is not the appropriate ins and outs, that could be the first sign that someone's going into shock because every other system is shutting down to shunt perfusion to the vital organs. So you may have tachycardia that's compensating, decreased urine output. Tachypnea is usually when they're in shock, they're getting short of breath because of the hypoperfusion. Altered mental status, they may be confused. Cool and pale or warm and flushed skin are the signs you're looking for on physical exam. There's a bunch of different categories of shock. Have you guys seen these before? Sort of. Okay. So cardiogenic shock is usually heart failure. This is because cardiac output is low and the heart is failing. Hypovolemia can happen with severe burn victims. Dehydration or hemorrhage is hypovolemic shock. It's a volume problem. The cardiac output is fine. There's not enough volume to perfuse the organs causing the shock. Vasogenic or distributive shock. This is more a problem with peripheral vasoconstriction. This is seen in sepsis, anaphylaxis. It's just everything's dilated. Nothing is getting perfusion because of the severity of the sepsis or the anaphylaxis or neurogenic shock. Obstructive shock is caused by obstructions like a PE, so an embolism somewhere. Tamponade obstructing the heart from beating can cause obstructive shock. The pre-shock states we talked about, right? The body will try to compensate with tachycardia, lowering the urine output to try to shunt everything to the main organs, preserve function. Shock happens when the compensation is overwhelmed. Kind of like if you think about what we talked about with heart failure, right? Your body can compensate to a certain point and then the system gets overwhelmed. And that's when shock happens and decreased perfusion to the organs will have its effects because the organs, there'll be evidence of end organ dysfunction. This is a nice little chart, kind of discussing what's going on in the body that distinguishes these from each other. So hypovolemic shock, when we talk about a pulmonary not the capital, it's capillary. Pulmonary capillary wedge pressure, this is taken from a central line or from a cardiac catheterization in the heart. So this is preload. Cardiac output, same thing. Usually these patients will have a central line in and you can, it'll give you a calculation for cardiac output. Normal cardiac output is over 2.4. Usually 2.4 to 4.5 is normal cardiac output. Systemic vascular resistance, this is measuring afterload. This is also something you can measure on a central line. So for hypovolemic shock, we have decreased preload. That makes sense, right? This is a volume problem. Either they're hemorrhaging and they don't have blood for that reason, they're dehydrated, or they could be a burn victim and that will cause interstitial volume depletion from the burns. So the pulmonary capillary wedge pressure, the preload will be low. Cardiac output will be normal or a little bit increased because it's trying to compensate. And the afterload will also be elevated. It's trying to compensate with peripheral vascular constriction to raise the blood pressure. The treatment for this is IV fluids or give IV fluids and blood as fast as you can. For cardiogenic shock, the preload is going to be elevated. This is can be evidence of increased volume status. So the patient will be hypervolemic. So they're going to have elevated pulmonary capillary wedge pressures. The cardiac output is going to be decreased. So it's going to be under 2.4 in these patients. That's how we're going to distinguish this. The afterload will be elevated or normal. We don't treat this the same as hypovolemic shock. We treat it with ionotropes to help give medications IV continuously to help the heart squeeze and promote contraction, and elevate the blood pressure. And ultimately, if the cardiogenic shock is due to a big MI, we need to revascularize the heart and take them to the lab once they're stable. Distributive shock is going to have a decreased pulmonary capillary wedge pressure, right? There's vasodilation, so the preload is going to be low. The cardiac output is going to be fine because the heart isn't the problem. The afterload is going to be low because everything is dilating. The arteries are dilating and the veins are dilating in distributive shock. That's why it's called vasogenic shock. All the vessels are dilated, preload and afterload. So they need pressors to maintain perfusion. Pressors will raise the blood pressure. And you do treat these patients with IV fluid. The tricky part of this is that we see in heart failure is if somebody goes into either distributive shock with heart failure, it's tricky to treat, right? Because you need fluids, you need pressors, but that may worsen the heart failure. So those patients are really difficult to treat. That's about all I want you to know about treating a combination of those. I want you to memorize those three separately and what makes the criteria on the central line findings. Getting a little bit more in depth into cardiogenic shock. This is when a state of tissue hypoxia due to reduced oxygen delivery in the presence of normal vascular volume. There's decreased cardiac output like we saw and hypotension. So remember way back when in our heart failure lecture, that little chart with wet versus dry, cold versus warm. When we talk about cardiogenic shock, they're going to be usually cold and wet or dry and wet. I'm sorry, cold. Yeah, they're always going to be cold and dry or cold and wet because cold means there's hypoperfusion. So that's the category these patients will present on physical exam. So there's a bunch of things that can cause cardiogenic shock with the heart. An MI. So if there's a huge MI and over 40% of that myocardial wall is affected, that could lead to shock just from that initial injury alone. Certain arrhythmias, like VT, VFib, can lead to shock. There's not adequate perfusion. Rarely do atrial arrhythmias lead to shock on their own. So if somebody's in like a very fast SVT or an AFib, the heart can tolerate that longer than it can with ventricular sustained arrhythmias. Can rapid AFib cause hypotension and decreased perfusion if you're in it long enough? Absolutely. But ventricular arrhythmias are more likely to cause that faster than atrial arrhythmias are. Acute heart failure, if there's actually a pump problem, like we talked about, if it's like a stage C or D heart failure patient on that little scale we talked about, that can lead to shock eventually if they become volume overloaded enough and the heart is weakened enough. Myocarditis can lead to this. Valvular disorders, if they're severe enough and have heart failure, can lead to these. An aortic dissection, like we talked about last class. Tamponade, beta blocker or calcium channel blocker overdose. So if somebody took so many AV nodal agents that now their blood pressure and heart rate is in the tank, that can also present as cardiogenic shock if it's severe enough. Clinical finding. Definitely know this little yellow thing right here. Their blood pressure will be less than 90 millimeters of mercury, systolic. The cardiac output that you get from a central line is going to be under 2.2 liters per minute. Pulmonary capillary wedge pressure is going to be above 18. This is considered elevated. And this is a nice little cartoon over here. Pretty much just everything we talked about already for those of you who like a little visual cartoon when you're studying. How do we treat this? Every single shock patient is going to get 2 large bore IVs, a central line and an arterial line for medications and fluids. You want to be able to give whatever medication you need as fast as you can for these patients because it is an emergency. And usually there's a large shock team and multiple members of the team will be doing this at the same time. So most important is the access. If you don't have access, you're not giving any meds or treatment or fluids or checking any type of pressure to see what type of shock it is. So that's important to establish that. Someone's usually drawing blood at the same time, CBC, electrolytes, renal function, PT, PTT, and blood cultures, right? If it's sepsis, that's going to help us out. We're getting an EKG, we're getting a chest x-ray, we're absolutely getting a bedside echo. That's going to clue us into what type of shock this is. The echo findings, what would we see in cardiogenic shock on an echo? What would the ejection fraction probably be? What's that? The opposite. So cardiogenic shock, it's the pump problem. So it's going to be lower. I'm trying to think if there's any scenario where it would be high. Usually think low, think under 40%. If it's an obstructive shock, what would we see on an echo? If it's an obstructive shock, what? Yes, right ventricular strain if it's a massive PE. And then what's another reason for obstructive shock? Sort of. What's that? Not aortic stenosis. Think around the heart. Tamponade. Exactly. So that's why we get an echo, because that's going to help us see right away at the bedside without sending a patient to CAT scan. Is the EF normal? Is there any RV strain? Is there any pericardial effusion that could be causing tamponade? So a bedside echo, 3 things can help you diagnose, and it's simple bedside echo. EKG, what are we going to see if it's cardiogenic shock? We might see, if it's an MI, we could see STEMI, right? We could see ischemic changes. We could see if it's an arrhythmia, if they're in VT, VFib, if they're in rapid AFib. So we can get all this information at once. Someone zooms in, hits us with a chest x-ray, we see it at bedside. It could be, do they have a large pleural effusion? Do they have pulmonary vascular congestion, suggestive of cardiogenic shock, heart failure? So those are all the reasons why we're getting those tests. Pulse ox, we want to know if this is low, right? If their patient's hypoxic, that's going to suggest probably cardiogenic shock. And we are determining if they need ionotropic therapy. If it's cardiogenic shock, we're determining if they need dobutamine, dopamine to raise their the contraction of the heart. Afterload reduction, do they need diuretics if they're in heart failure? This is tricky, right? Because if they're presenting with hypotension, we have to raise the blood pressure enough to be able to give diuretics in cardiogenic shock. Afterload reduction, we're not doing afterload reduction in vasogenic or distributive shock, right? Because the afterload is already low. And fluids in hypovolemic shock, vasogenic shock, not cardiogenic shock. Don't give fluids if someone's in cardiogenic shock. We're giving ionotropic therapy and we're diuresing them if they're in heart failure. And then of course the ABCs, airway, breathing, circulation, we're checking to make sure those are all stable as we're going through our workup. Seeing if the airway is clear, if we need to intubate, and how are we going to support their circulation? Is this by pressors and ionotropic therapy? Is it by fluid? Is it by putting in our balloon pump for cardiogenic shock? So those are what we're deciding and evaluating a shock patient for. And then we're treating the underlying cause. Is this an MI? We're going to stabilize the shock. We're going to take them to the cath lab. Is this tamponade? We're going to immediately drain the pericardium. Is this an arrhythmia? Do we need to shock? Bless you. Do we need to shock the patient, defibrillate the patient? Do they have a pulse? Is this rapid AFib? Do we need to cardiovert them? Balloon pump we chatted about a bunch of times. This helps support the heart, take the stress off of myocardial perfusion. It kind of perfuses the heart for the heart, so it has to work not as hard. These patients are always in the ICU, never on the floor. Shock patients, always the ICU. Need a central line, probably need pressor and ionotropic monitoring, probably need invasive procedures. So if someone's in shock or pre-shock, they're going to the ICU. And the Swan-Ganz catheter is basically a right heart cath at bedside that goes into the right atrium, and it measures cardiac output for us and left-sided heart pressures as well. Okay, so that's hypotension. A couple questions. Patient presents to the ER with chest pain. Examination of blood pressure revealed 202 over 123. It was a good blood pressure measurement. Cuff was good. Everything's working. Cardiac biomarkers are elevated and the CT head is negative for dissection, cranial hemorrhage, or stroke. The EKG shows ST depression. What is the next appropriate step?
E.
Let's see. Which one?
The E.
E? Okay. So why E?
Because there's no sample damage. But sorry, it's
So sort of. So there is end organ damage, but not the 3 exceptions to lowering the blood pressure quickly. So this is describing urgency or emergency? Emergency, because the troponins are elevated. Yeah, that counts. So this is describing hypertensive emergency. The caveat for this is there's no dissection, hemorrhage, or stroke. So that's still a hypertensive emergency, but those exceptions just kind of give us free rein, lower the blood pressure as fast as we can to 140 under 90, or get as close to 120 over 80 as possible. If there aren't those exceptions, we lower the blood pressure by 25% in the next hour. So a little bit slower. Everyone good on that?
Would the EKG changes also count for?
Yes, exactly. Sorry, what were you gonna say?
The answer is still E, though, right?
Still E, exactly. Okay, another case. I'm here for screening for a new job. We're in the office. So vital signs are 148 over 94. Pulse is 78. A 49-year-old male comes to your office for screening for his new job. He has some forms that needed to be filled out. He's asymptomatic. He's never been told he had high blood pressure before. He's not on any medications. His exam is completely normal. What is your diagnosis?
Stage 2.
Stage 2, 49. Yeah, stage 2 hypertension.
Isn't this like the only reading we have? Don't we need?
Wait, let me see this. A 49-year-old male.
Primary.
So this is the primary visit.
So it'll just be a reading.
So it would be, we would need to bring him back in a week, check his blood pressure again. If he still had this blood pressure, it'd be stage 2 hypertension. What if this guy had 160 over 100 and his EKG showed LVH? Can we diagnose it right off the bat? Yeah, exactly.
Wait, so
So this would be, you couldn't make a determination yet if he has hypertension or not. You'd do counseling, bring him back in a week, and you'd need the second reading. Yes, exactly. All right, so we did bring him back for a second visit. He has the same blood pressure. Yeah.
So if back and stuff, would that be stage 2 states?
It would be stage 2 because stage 1 is over 130 over 80. Stage 2 is over 140 over 90. Yes.
That would be essential hypertension.
Because you need it on 2 separate visits to really determine it. Because what if he was like nervous, had coffee, you counseled him on sodium restriction, lifestyle modification, and he still came back and it was that elevated, then he's diagnosed with it. Is there another question? No? Okay, cool. Let's see. Which of the following is an appropriate screening for test for this person at age 49? So he has 2 visits, elevated, stage 2 hypertension. What would we want to check for this guy?
E,
Which one?
E.
Exactly. So cholesterol. So I'm like, definitely EKG. I'm gonna say both A and E would be correct because we need to risk stratify him too, right? So the patient has a third blood pressure reading a week later, and it's still 146 over 93. Stage 2, 100%. Okay, and that's it, guys.
What's his initial?
So what's that?
Initial.
The initial test, I would accept A and E.
I think the next
wait,
slide, there's
oh, the
an
next
initial
slide.
treatment. Yeah, we just.
Oh, do you have it on there?
Yes,
Okay.
initial treatment.
So initial treatment for stage 2 hypertension, what are we treating this with? Thiazide diuretic, and possibly a second agent if needed, like an ACE or an ARB. And then we're definitely doing lifestyle modifications for this guy too, right? Any questions on that? Yeah.
Like, exactly, that wouldn't be safe. That would be, exactly, that would be like.
All right, guys, any questions on anything? Okay, before you guys jump out of here, I just wanted to give like a couple of take-home messages. It's our last class together. I just want to say it's been a pleasure teaching you guys, and I'm very excited for you guys to become clinicians. You're all very bright, and you ask really great, not always obvious questions. And when you guys go out into the field, carry that with you because there are going to be physicians and clinicians that have been practicing for 30 years. And that's how medicine moves forward, by you guys being new and fresh and asking those questions and thinking a certain way. And just keep in mind, I know you just had a poem and like the craziness of PA school, but you guys are here to learn as much as you can and ultimately be in a very special position where it's going to be you and a patient in a vulnerable spot who needs your help. And that is a very special position. And also being a PA is just going to give you guys so many opportunities. So I know like being in the game of didactic year, just keep that underlying thread because it's going to be worth it. And also, lastly, when you guys fill out the survey for this class, give me your honest feedback. This is the first time we combined the EKGs within the whole course. So if you guys feel like you wanted more like arrhythmias or you should have flipped the order of something, be totally honest. I know we can probably skip the fact that I need more lessons on PowerPoint